what your blood pressure number actually means. After 65, you've probably seen the videos, the ones that open with something like, "Your doctor is secretly harming you," or "The number they want you to hit could kill you," or "Drop a comment with your age and blood pressure right now." And maybe part of you wondered, is that true? Is there something real underneath all that drama? Here's my honest answer. Yes and no. Yes, the conversation about blood pressure targets in older adults is genuinely more nuanced than most 15-minute appointments allow for. No, the way that conversation is being had in a lot of online health content is manipulative, unverified, and in some cases actively dangerous. So today I want to do something different. I want to give you the real version of that conversation, with actual study names you can look up yourself, with the honest limitations of the research, not just the parts that make a good headline, and with one goal: to help you walk into your next doctor's appointment better prepared than you walked into your last one. Not to replace that appointment, to make it count. My name is Speaker Name. I'm a specialty at institution. Everything I tell you today has a citation you can verify. I'll read the study names out loud and they'll appear on your screen. If I'm telling you something science doesn't fully know yet, I'll say that too. Let's get into it. Here's a question I want you to sit with for a moment. When your doctor tells you your blood pressure target is 120/80, have you ever asked why that specific number? Not in a confrontational way, just genuinely curious. Where did it come from? Was it tested on people your age? Does it account for the fact that your cardiovascular system at 72 is physiologically different from what it was at 48? Most people haven't asked, not because they're incurious, but because the appointment moves fast, the doctor seems confident. And 120/80 has been repeated so many times it feels like gravity, like it was always true. But here's the thing about medical guidelines: they are not laws of physics. They are living documents, updated as evidence evolves, debated by researchers, revised by committees, and yes, sometimes applied more broadly than the original research intended. And one of the places where that broadness matters most is in how we manage blood pressure in adults over 65. That's what this video is about. Not to alarm you, not to make you distrust your doctor, but to give you the context that often gets left out when there are 15 minutes on the clock and 6 other things on the chart to cover. In 2015, a landmark study was published in the New England Journal of Medicine. It was called the Sprint Trial Systolic Blood Pressure Intervention Trial, average age just under 68, followed for an average of just over 3 years. The researchers divided participants into two groups. One group was treated to a standard target of less than 140 systolic, the top number. The other group was treated to a more aggressive target of less than 120 systolic. The results genuinely surprised people. The intensive treatment group, the one aiming for under 120, had a 25% lower risk of major cardiovascular events: heart attacks, strokes, heart failure. They also had a 27% lower risk of dying from any cause. Those are real numbers, meaningful numbers, and they helped shift guidelines toward more aggressive treatment for a broad population of adults with hypertension. Now, if you've watched other videos on this topic, you may have heard a version of that study used to argue the opposite point. Used to say lower targets are dangerous. That's not what Sprint found, but here's where I need you to pay close attention, because this is the part most videos skip entirely. Sprint had specific exclusions. People with diabetes were excluded. People with a prior stroke were excluded. People with advanced kidney disease were excluded. People living in nursing homes excluded. Anyone expected to live less than 3 years excluded. In other words, Sprint was designed to test intensive treatment in a relatively healthy older population. It was never designed to answer the question, what is the right target for a frail 83-year-old with diabetes, a history of falls, and 3 medications already? That's a different question, and the honest answer is we have less certainty there. A follow-up analysis published in JAMA Internal Medicine in 2019 by Williamson and colleagues looked specifically at the 2,636 Sprint participants who were 75 or older. The cardiovascular benefits held up in that older group. That's genuinely good news. Intensive treatment can help older adults too, but the intensive treatment group in the older subgroup had nearly double the rate of serious fainting episodes. 3.0% versus 1.6%. Falls weren't the headline finding, but they were real. And in a population where a fall can mean a fractured hip, a hospitalization, and a cascade of complications, that number deserves to be on the table. This isn't a reason to avoid treatment. It's a reason to monitor it carefully. And it's a reason why your target should be set based on your complete picture, not just a number on a guideline printed for a general population. Let me explain the physiology, because I think when you understand why the body behaves differently with age, the guidelines stop feeling arbitrary and start making sense as an ongoing conversation. The first change is arterial stiffness. Laurent and colleagues published on this in Hypertension in 2010. Your arteries are not rigid pipes. In a younger person, they're elastic. They expand when the heart pumps absorb the pressure wave and return to shape. As you age, that elasticity decreases. The walls of the arteries gradually thicken and stiffen, a process called arteriosclerosis. This has a very specific consequence for blood pressure measurements. It tends to raise your systolic number, the top one, while your diastolic number, the bottom one, may stay the same or even decrease. So you end up with what's called a widened pulse pressure. That gap between the top and bottom numbers gets bigger. A reading of 155/70 in a 78-year-old is not the same physiological picture as 155/70 in a 45-year-old, and treating them identically may not be the right call. The second change is baroreceptor sensitivity. Kevin Monahan published on this in the Journal of Physiology in 2007. Deep in the walls of your major blood vessels, especially in the neck and near the heart, there are tiny pressure sensors called baroreceptors. Their job is to detect changes in blood pressure and send instant signals to the brain, speed up the heart, constrict. The vessels compensate. In a younger person, this system responds within seconds. You stand up, there's a brief pressure drop, the baroreceptors fire, and the body corrects before you ever feel a thing. After 70, that system slows down, not because it's broken, because the sensors become less sensitive to rapid changes. This matters because if your baseline blood pressure is already sitting low due to medication, and your baroreceptors are slower to respond, the window between standing up and your body compensating gets longer. That window is when dizziness happens. That window is when people grab for the wall. That window, if it happens at the top of a staircase or in a dark bathroom at 3 in the morning, is when falls happen. The third change is how your body handles medication. Mangoni and Jackson published on this in the British Journal of Clinical Pharmacology in 2003. Your kidneys and liver are responsible for processing and clearing medications from your system. Both organs become less efficient with age, not dramatically but measurably. A dose of a blood pressure medication that produces exactly the right effect in a 55-year-old may produce a stronger, longer-lasting effect in an 80-year-old whose kidneys are clearing it more slowly. This is called altered pharmacokinetics in older adults. And it's one of the primary reasons why medication doses often need to be adjusted as people age. It's not a flaw in the medication. It's a physiological reality that requires monitoring. Now, none of these three changes mean that high blood pressure becomes acceptable as you age. Uncontrolled hypertension, systolic consistently above 160, remains a significant risk for stroke, heart attack, heart failure, and cognitive decline at any age. What these changes do mean is that the margin for error on the low end is narrower in older adults. The floor is higher, and the question isn't just, how do we get this number down, but how do we get this number to the place where the benefits of treatment clearly outweigh the risks? I want to spend a moment on something that gets misrepresented constantly in online health content. The 2017 ACC/AHA guidelines are frequently described as demanding that everyone aim for 120/80. That is not what they say. The guidelines do set a treatment threshold of 130 systolic for most adults, including older adults. But they also explicitly state that for older adults, targets should be individualized based on comorbidities, frailty status, and patient preferences. The European guidelines are even more specific. 339 recommend a systolic target of 130 to 139 for adults aged 65 to 79, not below 120, not 120/80. A range. For adults 80 and older, the European guidelines recommend 130 to 139 if tolerated, with a specific note not to push diastolic below 70. So here is the honest summary. The guidelines do not say 120/80 for everyone. The guidelines say treat hypertension, aim for under 130 systolic as a general target, but individualize, monitor carefully, watch for side effects, and use clinical judgment, especially in older, frailer patients. The gap isn't between the guidelines and your doctor. The gap is often between what the guidelines actually say and what gets communicated in a 15-minute appointment when there are 6 other things to cover. That gap is real, and it's bridgeable with a better conversation. I want to teach you something practical now, something you can do at home that takes about 10 minutes and gives you genuinely useful information to bring to your next appointment. It's called an orthostatic blood pressure measurement. Jurashek and colleagues published on this in the Annals of Internal Medicine in 2017. They found that in the SPRINT trial, intensive blood pressure treatment significantly increased the likelihood of orthostatic hypotension in older adults. Orthostatic hypotension means your blood pressure drops significantly when you stand up. The clinical definition from the American Heart Association is a drop of 20 or more points in systolic pressure or 10 or more points in diastolic pressure within 3 minutes of standing, not immediately, within 3 minutes. This is an important detail because some online videos tell you to measure the moment you stand. That's not the clinical standard. The standard is 1 minute after standing and 3 minutes after. Both measurements matter. Here is the correct protocol. First, lie flat on your back for 5 full minutes. Not sitting. Lying flat. Let your circulation fully settle. Second, while still lying down, take your blood pressure. Record both numbers. Write down the time. Third, stand up at your normal pace. Not slowly and carefully your normal pace, how you'd actually stand up during your regular day. Fourth, set a timer. At the 1 minute mark, take your blood pressure standing. Record both numbers. Fifth, stay standing. At the 3 minute mark, take it again. Record those numbers too. Sixth, compare. Subtract your standing systolic readings from your lying systolic reading. If either standing reading is 20 or more points lower, that is a clinically significant finding worth discussing with your doctor. What does this mean if you find it? It doesn't mean your blood pressure medication is wrong. It means there is data worth discussing. Maybe the dose needs adjustment. Maybe the timing of when you take your medication matters. Maybe there's a different medication with a gentler profile. Those are conversations your doctor can have with you if you walk in with the numbers. On home monitoring more broadly, the American Heart Association published a scientific statement on this in Hypertension in 2019. Use a validated upper arm cuff, not a wrist monitor. Wrist monitors are less accurate, especially in older adults. Measure in the morning before taking your blood pressure medication, after using the bathroom, before eating or drinking coffee. Measure in the evening before bed. Take 2 to 3 readings each session 1 minute apart. Record all of them and average them. Do this for 7 consecutive days before an appointment. That average gives your doctor far more useful data than a single office reading. And about that office reading, research consistently shows that being in a clinical setting can raise blood pressure by 5 to 15 points or more. It's called the white coat effect. It's real. It's common, especially in older adults. It doesn't mean your home readings are right and your office readings are wrong. It means both are useful pieces of information, and the combination tells a fuller story than either one alone. Now, I want to talk about something that often gets treated as secondary, but in my view belongs at the center of this conversation. Medication is not the only lever. I say this not to discourage treatment. I say it because lifestyle changes are the one intervention that improves blood pressure without adding side effects, without increasing fall risk, and without requiring a prescription. And in older adults, some of these changes are powerful enough to meaningfully shift the equation. Let me be specific, because eat better and exercise more is advice people have been ignoring for decades, and usually because it's delivered without enough detail to actually act on. The first and most impactful change is sodium reduction. As you age, your kidneys become less efficient at excreting sodium. This means dietary sodium has a larger effect on blood pressure in older adults than it does in younger people. The current general recommendation is under 2,300 milligrams per day. For older adults with hypertension, under 1,500 milligrams is the more relevant target. To put that in concrete terms, a single restaurant meal can contain 2,000 milligrams or more. A can of soup, 800 to 1,000. Deli meat, bread, cheese, sodium is embedded in processed food at levels most people don't realize until they start reading labels. The single most effective dietary change most people can make is cooking more meals from whole ingredients at home. Not because it's cheap or easy, it often isn't, but because it is the only reliable way to know what you're actually consuming. The second change is movement, not marathons, not gym memberships. Movement. Research published in Hypertension, a meta-analysis by Cornelissen and Smart in 2013 found that regular aerobic exercise reduces systolic blood pressure by an average of 3.5 points in people with normal blood pressure and by 8.3 points in people with hypertension. That is a clinically meaningful reduction. comparable to a low-dose medication without the side effects. The recommendation from the American Heart Association is 150 minutes of moderate intensity activity per week. That's 30 minutes 5 days a week. And if 30 consecutive minutes feels like too much, 3 10-minute walks throughout the day produce similar cardiovascular benefits. The research supports breaking it up. What counts as moderate intensity? You should be able to carry on a conversation but not sing comfortably. Brisk walking qualifies. Swimming qualifies. Cycling qualifies. For most older adults, walking is the most accessible, lowest risk starting point. The third change is sleep. This one surprises people. Poor sleep, and specifically obstructive sleep apnea, is one of the most under-recognized contributors to hypertension in older adults. The Wisconsin Sleep Cohort Study, published in the Journal of the American Medical Association in 2000 283.14.1829, found a clear dose-response relationship between sleep apnea severity and hypertension. Treating sleep apnea with P continuous positive airway pressure can reduce systolic blood pressure by 10 points or more in some patients. That's not a marginal effect. That's the equivalent of adding a second blood pressure medication. If you snore loudly, if you wake up unrefreshed regardless of how many hours you slept, if your partner has noticed you stop breathing during the night, these are symptoms worth discussing with your doctor before adding another antihypertensive medication to your regimen. The fourth change is stress. Chronic activation of the body's stress response, sustained elevated cortisol and adrenaline, keeps blood vessels in a state of mild constriction and elevates blood pressure over time. The research on specific stress reduction interventions is less clean than the research on sodium or exercise. Different techniques work differently for different people, but the principle is consistent. Chronic psychological stress is a physiological stressor with measurable cardiovascular effects. What actually helps varies by person. Meditation helps some people significantly and does nothing for others. The same is true of yoga, tai chi, spending time in nature, social connection, creative work. The variable isn't the activity, it's whether it genuinely produces a sustained sense of calm for you specifically. The honest framing is this: if you're managing blood pressure with medication and your life contains chronic unaddressed stress, the medication is working against a headwind. Addressing the stress doesn't replace the medication, but it changes what the medication has to overcome. I want to be clear about something. I'm not suggesting that lifestyle changes alone are sufficient for everyone. For many people, the combination of age, genetics, and cardiovascular history means medication is necessary regardless of how well they eat or how much they walk. But lifestyle and medication are not alternatives. They are layers. And the more effectively you manage the lifestyle factors, the less work any medication has to do and the lower the dose required to reach a safe target. Now, I want to say something directly to the people watching this who are not the patient themselves. If you are the adult child of someone over 70, if you're a spouse, a sibling, a close friend, if you clicked on this video because you're worried about someone else, you are a part of this conversation, whether you realize it or not. Here's something I've seen repeatedly over decades of practice. An older adult has been managing their blood pressure quietly, independently, without complaint. Their numbers look fine on paper. Their doctor is satisfied. But at home, their family has noticed things. They stand up from the dinner table and pause before they walk. They've become more hesitant on the stairs. They've stopped doing the things they used to do, not because they said they were afraid, but because they've quietly arranged their life around a physical uncertainty they've accepted as normal. Often, it's the family member, not the patient, who first notices the pattern. And often it's the family member who, if they knew what to look for, could be the one to bring it to light. If someone you love is on blood pressure medication and you have noticed any of these things, dizziness on standing, new hesitancy in their movement, unusual fatigue, or episodes they've dismissed as just a little dizzy spell, that is worth a conversation, not an accusation, not alarm, a conversation. You can help them do the orthostatic test I described. You can help them keep the 7-day blood pressure log. You can go with them to the appointment and ask with their permission whether the orthostatic measurement has been done recently. Being an informed family member is not being overprotective, it is being present. And in the management of chronic conditions in older adults, having someone in the room who can describe what they've observed at home calmly, specifically, without catastrophizing, can genuinely change what gets discussed. Now, I want to spend a moment on something you will almost never hear in health content online. I want to tell you what science doesn't fully know yet, because I think you deserve that honesty. We don't have strong randomized trial data for blood pressure targets in adults over 85 who have multiple chronic conditions and frailty. The best available data comes from the Hypertension trial, New England Journal of Medicine, 2008 targeting under 150 systolic in adults over 80, but HYVET also excluded frail patients. So for the oldest, most medically complex individuals, the ones who arguably need the most guidance, we are still working from incomplete evidence and clinical judgment. We don't have definitive answers on blood pressure and dementia risk. Some studies suggest that high blood pressure in midlife increases dementia risk decades later. Some studies suggest that very low blood pressure in late life may also be associated with cognitive decline. The relationship is real and being actively researched, but anyone who tells you they have the definitive answer is ahead of the evidence. We don't have a one-size answer for how aggressively to treat isolated systolic hypertension, high top number, normal bottom number, in adults over 80. Guidelines give ranges. Researchers debate the edges. Clinicians make judgment calls based on the individual in front of them. I tell you this not to undermine confidence in medicine. I tell you this because this uncertainty is exactly why your individual conversation with your doctor matters. No video, including this one, can know that you had a fall last year, or that your diastolic has been trending down, or that you've been sleeping badly and feeling lightheaded by noon. Your doctor can. The most useful thing I can leave you with isn't a target number. It's a framework for a better conversation. Here are 3 questions worth bringing to your next appointment, not as challenges, not as accusations, as collaborative requests for information you deserve. The first question, given my age and my complete health picture, my other conditions, my medication list, my history of any dizziness or falls, what is the specific systolic target you're working toward for me, and how do you account for the risk of blood pressure dropping when I stand up? This question does something important. It signals that you understand this is an individualized decision, not a universal number, and it opens the door to the orthostatic conversation, which often doesn't happen unless a patient introduces it. The second question, I've been doing home blood pressure monitoring. Here are my readings over the last 7 days. I also did the sit-to-stand test and found my pressure drops. X points when I stand up after 1 minute. Can we look at these together? Arrive with paper. A physician presented with home data responds differently than a physician responding to a vague description of feeling a little off. Data invites clinical thinking. Vague symptoms invite reassurance and a return appointment. The third question, I've been experiencing dizziness on standing or morning fatigue or brief moments of lightheadedness. Could any of these be related to my blood pressure running lower than is optimal for my age? I want to make sure we're not missing a medication effect. This question matters because many physicians are trained to investigate causes of high blood pressure. The possibility that treatment itself has created a new problem sometimes requires the patient to introduce it directly. You are not being difficult by asking these questions, you are being precise. And in medicine, precision is the difference between a medication adjustment that changes how you feel for years and another 12 months of quietly adapting to symptoms that didn't have to be normal. One more thing before I close. I want to tell you what to watch for the signs that blood pressure is genuinely too high and needs attention, regardless of age, regardless of everything I've said today. Because I don't want anything in this video to become a reason someone delays care they actually need. If your systolic pressure is consistently above 180, that is a hypertensive urgency. It needs same-day contact with your doctor or an urgent care visit. If your systolic is above 180 and you have chest pain, severe headache, visual disturbances, difficulty breathing, or weakness on one side of your body, that is a hypertensive emergency. That is a call to 911, not a video to watch, not a home test to run, a call to 911. Moderately elevated blood pressure, 140 150 S. It is a conversation to have at your next scheduled appointment with home monitoring data in hand. It is not an emergency, but it is also not something to ignore indefinitely because you feel fine. The reason high blood pressure is called the silent killer is exactly that. It causes damage without causing symptoms until one day it causes a symptom that can't be undone. The goal of everything I've described today is not to lower the urgency of treating hypertension. The goal is to make the treatment smarter, more individualized, better monitored, and less likely to create new problems while solving an existing one. Let me bring this together. The research on blood pressure in older adults tells a story with genuine nuance. The SPRINT trial showed that intensive treatment reduces cardiovascular events even in people over 75. That finding is real and it matters. The same trial showed that intensive treatment increases the risk of fainting and orthostatic hypotension in older patients. That finding is also real and it also matters. The current guidelines, both American and European, do not mandate 120/80 for all older adults. They recommend individualized targets, careful monitoring, and clinical judgment. The physiological changes that come with aging, stiffer arteries, slower baroreceptors, altered medication metabolism mean the margin for being too aggressive is narrower in older bodies than in younger ones. Lifestyle changes, particularly sodium reduction, regular movement, and treating sleep apnea are not alternative medicine. They are evidence-based interventions that can meaningfully shift blood pressure and reduce the work any medication has to do. If you have people in your life who are managing this, people you love and worry about, your attention to these patterns is not interference. It is care in a form that actually helps. And there are real questions science is still working on about frailty dementia and the very oldest patients where honest clinicians will tell you the evidence is still evolving. None of this means blood pressure treatment is wrong. It means blood pressure treatment is a conversation, an ongoing, individualized, monitored conversation, not a one-time target set and never revisited. Here's what I'm asking you to do this week. If you're on blood pressure medication and over 65, do the orthostatic test I described. Write down your numbers. Start your 7-day home monitoring log. Then bring that paper to your next appointment. Not to argue, not to demand a different number, to give your doctor more complete information than they usually have. That's it. That's the whole ask. The links to every study I cited today are in the description below. Not a supplement, not a product. The actual papers. So, you can read them yourself or share them with your doctor if you want to. I want to leave you with something that has stayed with me across many years of practice. The patients who do best over time are not necessarily the ones who follow every instruction perfectly. They are the ones who stay curious, who keep asking questions, who treat their health not as a report card to pass or fail, but as an ongoing conversation between what their body is telling them and what the evidence supports. That kind of curiosity doesn't require a medical degree. It requires attention, a notebook, and the willingness to say at your next appointment, "I've been paying attention and here's what I've noticed." That sentence said calmly and specifically with a piece of paper behind it changes what happens next in that room. That's the conversation worth having. Take care of yourselves. I'll see you next time. All studies cited in this video are linked in the description below.